Yeah. All right. Good afternoon, everybody. It is really my pleasure to introduce Dr. Isabella Glitza. She's a professor in the Department of Melanoma Medical Oncology, University of Texas MD Anderson Cancer Center. She's an internationally regarded clinician scientist whose leadership and contributions have shaped the field of melanoma care and research. As a little bit of background, she completed her medical and doctoral training in Heidelberg, followed by residency and fellowship training in internal medicine, hematology oncology at Einstein and MD Anderson. She joined the MD Anderson faculty, where she is now professor, achieving tenure track status effective last year. Congrats. Dr. Glitza serves in a number of leadership roles, including Deputy Chair of Melanoma Medical Oncology, Director of the Melanoma Fellowship Program, Co-Chair of the Credentials Committee of the Medical Staff, and Director of the Leptomeningeal Disease Research Program. She's also made extensive institutional contributions through the Faculty Senate, where she has served as chair. Her work has been recognized with multiple honors, including repeated national top-tier patient experience rankings, the Melvin L. Samuels Award for Excellence in Patient Care, and early career awards from ASCO and AACR. Please join me in welcoming Dr. Glitza.
Thank you for the super warm welcome. It's been amazing. So everybody who I met has been kind, and I decided to take you on a little journey, and I tried to come up with a cool and smart, title for my talk, which is always hard, but my passion is leptomeningeal disease, specifically in melanoma. And I think the question always has been, do we find the future really right in our front yard with a nice picket fence, or do we actually have to go all the way to Mars to make a difference in patients' outcomes? These are my disclosures, but first, I don't think everybody in the room, and so I apologize for the audience not really knowing the composition, but I wanted to I love history, and so really just giving you a timeline, and you probably see this in a lot of talks, but I thought it was so cool, and I'm going to show you on the next slide. Of course, a German described leptomeningeal disease for the very first time in the literature, and it was a crazy case where a woman was committed to the, I don't know what the politically correct word is, but German translation is crazy people house, with just being altered and not really the loving wife that she was at one point. And then subsequently the word leptomeningeal disease was coined. But what's really cool and what I've really based my career on is using intrathecal immunotherapy. So for those again who might not know intrathecal means direct injection into the spinal fluid. And that can be, am I too far from the podium? Okay, yeah, I'm going to stay way back. Okay, then. Okay. So intrathecal immunotherapy started back in 1975 with the use of, again, interferon and actually herpetic encephalitis. And then actually we at MD Anderson, my former mentor, used interleukin-2, which you all know is a cytokine that's highly inflammatory and does a lot of really bad things in the CSF. But one thing that it does, and I will show you some of the data too, it opens up the blood-brain barrier and it pulls in a lot of the immune cells right into the space. And as you all know, immunotherapy or just the immune system is really crucial in fighting cancer, even in the third space that we consider the CSF to be in. We've done intrathecal T-cell therapy, or TIL. I know again that you have a strong science research program around TIL. So back in 2010 and 2018, we injected 2 patients with their own T cells intrathecally again. And then we developed a trial using intrathecal checkpoint inhibition, initially in nivolumab PD-1, followed by also CTLA-4 and PD-1 with our colleagues in Switzerland, Emily Leroux, who's a leader in Europe for LMD. And we've more recently finished actually our enrollment for Nivorella, and are currently working on endogenous T cells or NK cells for the space. So I think this is the timeline that I think is just interesting to see. And now I somehow did something, but I have a mouse here. Good, perfect. So again, the first description, as I mentioned, was given on the right. I know not all of you can speak German, but it says zur Entwicklung des Epilioms. So again, this was the case about this loving woman who became not really nice to her husband anymore, and then subsequently died very briefly from, again, what appeared to be leptomeningeal disease. But again, you can see that actually in the 1870s, the phrase leptomeningeal disease was first described as carcinomatosis, and then subsequently we also identified for the first time really cancer cells within the CSF. And I don't know if you can see it very well, but it's a really cool initial drawing again from Ebert, but also from Oliver in 1837, is how they saw those cancer cells just surrounding the meninges and the blood vessels. But so how often is actually leptomeningeal disease? And I know there's a mix of different oncologists in the room and students probably and postdocs, but actually it's way more common than you think, or again, maybe not even have heard of. So if you think of brain metastases, so the way I describe it to my patients, brain metastases is when you think of a pecan or walnut, it's what's under the brown skin. That's kind of inside the nut. Leptomeningeal disease is on top of the brown skin. Think of it, you took some powdered sugar, you put it on top of the meninges, so it can be everywhere, so kind of note to yourself. It's hard to maybe target with radiation as if it was in just one spot. And again, brain metastases are affecting about 200,000 patients in the United States each year, but we probably see about 110,000 of leptomeningeal disease patients per year as well. Now, one thing to know is often it's more in advanced patients, meaning they've had multiple lines of therapy. Most often they actually have brain metastases at the same time, so that is, again, one of the risk factors. And we do think and know that the CSF is probably even more of an immune preserved or secluded area that's actually even further different from your brain parenchyma immune system. Melanoma, unfortunately, leads the incidence of leptomeningeal disease. So again, for you to know, brain mets in melanoma, we see in up to 50–70% of patients with stage 4. We see about 20–30% of patients with stage 4 will develop leptomeningeal disease. And unfortunately, and again, I know we have neuro or radiation oncology in the room too, we think that part of the incidence rising is not only due to, again, patients living longer, developing disease in certain niches in their body, but also improved detection with better MRIs. And again, people being more aware of this being a cancer complication. Now, the challenge is, though, again, how to diagnose leptomeningeal disease. And that should sound very straightforward, but it is actually not. And the 5 pictures that I put up there on the right, I would call leptomeningeal disease for the blind or for the unexperienced. So you all should see that there's weird things going on in certain areas. And what I mean by this, and let's see if this works, the pointer, nope, but we can use maybe a mouse. Yeah. So you can see some fluff here in the MRI, which is not really as strong in the other. On this one, you see little white nuggets or intraventricular tumors. Here you see more diffuse caking of the ventricle. Here you would say, maybe all these little white lines are really just blood vessels, but this is actually diffuse leptomeningeal disease. And this is somebody's spinal cord that should actually look nice and gray and nicely delineated, that is completely caked with leptomeningeal disease. And it tends to be down at the bottom of the spine when people have then issues walking or they have issues going to the bathroom, because again, these nerves really regulate your whole GI system or your bladder control. So people often say, I can't really feel when I have to the bathroom anymore, or they can't urinate. But so again, these were like very clear examples of LMD. I mean, everybody who has looked at an MRI or ever look at MRIs should be like, oh my goodness, this is LMD. But unfortunately, these are not typical examples. So gold standard remains a lumbar puncture. But as you can see, the sensitivity is probably less than 50%. So even with pictures like this, where we see a lot of cancer in the ventricles or around the spinal cord, the lumbar puncture only shows cancer cells in maybe about 50%. So it's not a good diagnostic test. And so new technologies, which is not that new actually anymore, but like cell-free DNA or circulating tumor cells are really things that we use to really also track potentially response and improvement. But the one thing that we also struggle, I mentioned that you have often brain metastases at the same time. There is some data that shows that when the brain metastases sit right under the brown skin of the meninges, again, I'm using it a little bit more colloquial, that cells can leach, or tumor DNA can actually leach into the CSF without truly having leptomeningeal disease. So that's just something to consider. An MRI is sufficient, especially if it looks like the pictures on the right. But again, the sensitivity depends on the experience of the radiologist and ranges, again, from 20 to 91. The reason why I'm highlighting is because, again, I see a lot of LMD patients per year. And a lot of the times is that they come in after they had multiple MRIs on the outside that looked suspicious, but just didn't reach the suspicion for the local radiologist to call this leptomeningeal disease. And then unfortunately, what I will show you on the next slide, it's too late. So maybe to put your view right at this. So this is leptomeningeal disease from melanoma, because I'm a melanoma doctor by training. And what you can see that in general, and these are multiple large cohort studies, 178, 172, 137, from our institution with some other smaller cohort series reported in the past from other centers, but in general, a very young age, early 50s. Also, a way higher number of BRAF mutations. So again, for you who don't treat melanoma often, BRAF mutation is about 45 to 50% in your general cutaneous melanoma population. You can see that we're hitting numbers that are higher in the 60s, close to 70s, meaning we know that actually BRAF mutation is a risk factor for the development of leptomeningeal disease. But the biggest part actually that I want to highlight is the median overall survival. And even forget the 8 months, which is somewhat something we get excited on the very, very far right, which is including patients that were diagnosed between 2021 and 24 with 8 months. This is horrible, right? I mean, most other cancers, we're looking at much larger numbers. And if you look right next to it, between 2015 to 2020, when we already had all the double checkpoint inhibition with Ipi/Nivo, we have BRAF/MEK, we have chemo, we still are looking at just a few months survival. So what I'm trying to maybe take home, it's hard to diagnose, it's underdiagnosed, and the survival still remains really, really poor, even in 2026, where we've had so much really improvement, not just in melanoma, but in many other types of cancer. So now let's move forward to checkpoints, right? Checkpoint is what we've been doing for over a decade, actually 15 years now in melanoma, with the ipilimumab being FDA approved in 2011. And so when you look at some of the other leptomeningeal disease studies that use checkpoints, either pembrolizumab or Ipi/Nivo, in patients with LMD, the first part that I would criticize, but that's not the author's fault. I actually know Priscilla very closely, Priscilla Brastianos in Boston. But it really only included 2 melanoma patients in all these 3 studies. Again, not big numbers. You can see 2018 and 13. But importantly, which you will see here, the immunotherapy was given intravenously, and these patients never had prior checkpoint inhibition. So this is going to be a very stark contrast to the melanoma data that I will show, where pretty much every patient had prior exposure to checkpoints, to either PD-1 or the combination, because it is part of our neoadjuvant approach, it's part of our adjuvant approach, it's part of our approach to brain metastases. So that's just a slight difference. But what you can see here, even these studies were exciting for the field. You can see median overall survival still of only 3.6, 2.9 months, or about 5 months. So again, key takeaway is it's horrible. But we've had some small changes, and again, this is what I'm very proud of the team back at home at MD Anderson. We took a look at our trial, and we took at the current guidelines in the NCCN, and you can see that it says, you know, you can do intra-CSF therapy. That's kind of right here if the patient might be fit enough. And again, this means historically chemotherapy, which does not work in melanoma when given intrathecally. And we were able to actually add intrathecal nivolumab to the guidelines for patients, again, with melanoma. However, again, full disclosure, and I can share we've treated patients also with lung cancer with this approach and renal cell carcinoma, because again, these are cancer types that historically have shown to be PD-1 responsive. So again, I think we're broadening this approach to other tumor types. But more publications have been happening since then, including some case reports. But the big question is, and I don't know if you know what game this is, I didn't. I don't know if the gamers in the room, if you know that. But anyway, how did we get here, right? How did we manage to change the NCCN guidelines based on really just one single trial? So it was a long journey, and that's why I wanted to really show you the timeline. So again, it started with interferon in 1975. Like I said, it was used for herpes infection in a neonatal patient. And then subsequently, they tried it in melanoma. It didn't work very well. Again, it was only 2 patients. But then intrathecal IL-2 came, and I'm going to go through the data on the next step. So what we did, we inject any patient that we have with intrathecal therapy through an Ommaya. So that's the little port, as we can tell it, that goes right into your CSF. And that's super nice for the patient because it is really pain-free, and it allows for repeated injection. It also allows for repeated CSF removal, so they don't have to go through the lumbar puncture and go through the pain. So it's just a very nice way of also collecting samples, for example. But so all patients have this Ommaya, and then we used 1.2 million international units of IL-2. And for those who do TIL therapy, you know that this is actually a dose that we give also by vein. And patients are hospitalized for up to 1 month. The reason why I'm highlighting this is because if you only have 2 or 3 months to live, 1 month is a pretty tough investment, especially if the majority of patients will still die. And again, I think we have to, as oncologists, always think about not just science, but we have to think about our patients. What does it mean to put them into the hospital for a month? The bad part is I'm not only putting them into the hospital for 1 month, I treat them daily, and I make them sick. I make them extremely sick. Because why? Because IL-2 induces all kinds of different other cytokines, and what happens in their brain, you cause meningitis, you cause massive inflammation, irritation. They have fevers, they have nausea, vomiting, they might get kind of semi-comatose, they might have seizures, which is very rare. But we're truly creating, through our drug, a meningitis that, though in effect, will pull in your immune cells that you want. So initially you will have a neutrophilic infiltrate that really doesn't do much. But then on day 3, day 4, day 5, you will see a sustained lymphocytic infiltrate. And we did some flow studies that I didn't actually put in here that showed, though, that in patients who had a high CD8 positive profile, these lived much better than patients who had, more Tregs or CD4s. But again, can I decide on who's going to get the good killer cells into their CSF or not? No, I can't, right? You just open the floodgates and hope that the patient actually has a good outcome. But it makes them extremely sick. And did it help? Some of them. So we reviewed this, a series of 43 patients that were treated between 2006 and 2014. And as I just mentioned, they also have to be fairly fit, right? Because if they're not fit, they cannot be so sick, they would deteriorate and literally die from the treatment. And the median overall survival from initiation was about 7.8 months. Now, again, you'll say, that's a hard number, right? It's not great, and it's a big investment. But we had some patients that actually survived at 5 years, 13%, which is actually fantastic. It's somewhat similar to the initial ipilimumab data in metastatic melanoma. And our patient that has been surviving the longest, who's now 31 years out. So I saw him actually just last week in clinic. He still has the Ommaya in place. He hasn't gotten treatment in about 15 or 20 years. And he refuses to take the Ommaya out because he says, just in case, Dr. Glitza. And we decided he's now in his late 70s, we're just going to leave him alone. But again, this was kind of the basis of why we then decided to move forward. And again, a few things to consider. The deterioration in your performance status is 100%. If you come in with a performance status of 0, you will get to at least an ECOG of 2, which again is very tough. So not everybody will be able to really deal with this. And again, you have to be highly selective. So another thing, again, it's deadly. It can kill you within a few weeks. You might not benefit. You're in the hospital for a month. Doesn't affect your non-CNS disease. So again, if you have brain metastases in addition or extracranial disease, the intrathecal IL-2 will do nothing for it, unfortunately. And again, patients who did worse at baseline were with baseline positive CSF, which we think, again, is maybe a surrogate marker for just disease burden, and patients who had concomitant targeted therapy. And the thought is, again, for those, again, who know BRAF inhibition in brain mets, the duration of response is only 6 months. So if you develop brain mets while you're in BRAF-MEK, you're kind of doomed because we don't have anything else to give. And if you have LMD, and develop LMD while you're on BRAF/MEK, you're doomed even more, which I think for lung cancer, we can think about osimertinib, right? It's a great drug if you have LMD, might work for a year, but if you develop LMD while you're on it, you're actually in much worse shape. Your survival will be significantly shorter. But that was kind of an initial glimpse of some people can live way longer than what we ever seen with intrathecal IL-2. And then we thought about, okay, there is this concept of using intrathecal administration of drugs like rituximab. Again, I talked to you about interleukin, about using Herceptin is being used intrathecally too, to really trying to dose intensify the concentrations of drugs within your CSF space. Because there was some data that when you give rituximab by vein, does it cross? Surprisingly it does, even though it's an antibody, but the levels are 400 to 1,000 times lower. For checkpoint, at the time when we designed our intrathecal nivolumab trial, we had no idea how much PD-1 gets into the brain. We had no idea. We didn't even know how to measure it. But later on, publications came out, again, showing that the antibodies can cross through, but the levels are up to 300 times less. So again, the concept was if you inject it straight into the spinal fluid, you will intensify the dose. And to kind of further support this, what we did actually, this is data actually from Chantal Bernatchez and Kara Haymaker, who we talked briefly earlier about, is we actually found PD-1 expression on the immune cells in the CSF, so we had a target. So scientifically, it also made sense to try to do it and not just blindly doing it. And again, it was also based that we knew that IT delivery of antibodies was safe through other cancer types like breast cancer, where we use Herceptin, rituximab for some leukemias and lymphomas. And again, if you think about how toxic IL-2 is, even systemically given, PD-1 is compared to this really very, very low risk, very low side effects. And so we hoped that using checkpoint inhibition straight into the spinal fluid would be not only beneficial, but also safe. We had to do mouse studies, extensive mice. We started off by using methylene blue to inject into the cisterna magna in mice. And it was extremely hard. That's why I had a very skillful collaborator, Dr. Ferguson, who's a professor at MD Anderson in neurosurge. And she would inject, many, many mice just to show we are right in target with a methylene blue. And then, again, we would move forward and do some studies that you can see up there, both with PBS, but also with murine anti-PD-1 to show safety. And again, the mice lived well. None of them showed changes in behavior or weight, which is sometimes a way to look at mouse health, as you all know. And then when we did analyze the mouse brains, we really didn't see any infiltration. Again, the concern was to maybe have some encephalopathic inflammation that is more diffuse, but we didn't see it. We did sometimes see a little area of increased immune infiltrate, but this is where the needle kind of went right into the cisterna magna, and we think it was more pressure injury when we injected the mice with the volume right into the CSF. So we developed a trial, and it was a first-in-human trial. Again, for the younger audience, is never give up. If you have something in your mind that you think can work for your patients, follow your heart and just bug the companies. And it took me years to get finally Bristol Myers to agree to give me some money for the trial, but I probably had to wait for 2 leadership changes within BMS, had talked to every other company that's out there for checkpoint, but never give up. So we finally ran this trial. We enrolled the first patient on June 3rd, 2017. After literally 2 or 3 years of really trying to find funding for it. And again, primary objective first in human was obviously safety. And I just realized I didn't put a safety slide in, but please trust me, it's an incredibly safe approach. I think I completely forgot to put a safety slide in. But we treated 50 patients. The majority of patients had melanoma. Again, we treated 2 with lung cancer. 1 lived for nearly 2 years. Despite having had multiple lines of therapy. And again, most of the patients that you can see somewhere down there had actually prior, where did the mouse go? There it is. Nearly 90% of patients had prior immunotherapy. So again, these are pre-treated patients that were not PD-1 naive, but they were actually refractory. We had different dose levels, and we did some really fancy but crude calculations on how big is the dose in the blood, or what's the concentration when you give the drug IV, how much CSF do we have, and again, also mimicking in how much we injected the mice with. And so we ultimately decided that maybe a recommended dose would be 50 milligrams IT-Nivo, which we ended up doing. But a couple of other things that I wanted to maybe point out. We also had, and this is important for the survival data, we had some really funky and rare subtypes in our cohort as well. So acrolentigenous, again, for those who don't treat melanoma, it's typically when the melanoma comes from your hands and feet or nail beds, and that's associated with a poor prognosis to checkpoint. The other one that's actually even worse in regards to outcome with checkpoint is mucosal melanoma. They also tend to respond, again, less well to immunotherapy, and so does uveal, which we had 3 patients. And finally, some of you might have never heard of primary CNS melanoma. It's an extremely rare subtype. I've seen all of them at MD Anderson in my career, and I've seen about 23, which is extremely rare. It's something that derives truly from the melanocytes or melanocyte type in the neural crest that is similar to your melanocytes in your skin. And it's often very devastating because it's only being diagnosed when this disease in your brain becomes pushy on certain parts, like, for example, your spinal cord, where people present with spinal cord symptoms, and then the surgeon takes it out and says, oh my, this is a very weird melanoma type tumor. And again, it has a GNAC and GNA11 structure, a genetic signature, so you can kind of guess what it is. And it's just really unknown how to treat them. So again, I want to highlight that the cutaneous melanoma patients were actually not the majority. And again, that we had a good number of what I'm going to call just the weird ones. We also had a good number of unknown primaries, just simply what we see at MD Anderson. So what's the median overall survival? Again, you're going to say, 7.5 months, you really didn't make a big difference. But again, I know I didn't put the safety slide in there, but it was extremely safe, meaning we didn't have any CNS toxicities, no seizures, no encephalitis, no meningitis, and we do have the tail of the curve. And again, overall survival at 12 months was 35%. And the first patient that I just mentioned that was treated, median overall survival, not median overall survival, on June 3rd, 2017, he's still alive, and I'm going to show you a picture of him later on. So again, now heading into his, I can't do the math, 9th year of treatment. He's still actually getting the treatment every 2 months because he's also too scared of just getting off. And interestingly, and again, I'm really interested if there's any thoughts on this or neuro-oncologists in the room, he still has positive CSF on occasion. And we can't figure out how this is still possible. And the pathologists have confirmed that these are truly melanoma cells that they keep on seeing in his CSF off and on. But somehow the disease remains controlled and he's living life, even though he was initially in a wheelchair when we started treatment. So I'm going to show you this. But again, we don't want to sit and stop and say, okay, we've made an impact in some patients, we got into the guidelines. Right, the goal always should be what can we learn, how can we improve upon, how can we do better? And so naturally, the Relativity 047 study came out in 2020 or 18 for melanoma, again, not including brain metastases, but it compared Nivo to Nivorella, a LAG-3 plus PD-1 inhibitor. And Nivorella did better than Nivo without a lot of side effects. So we thought, okay, maybe we should just add the combination now into the spinal fluid. Why not? Makes sense. And so we designed another trial using intrathecal PD-1 plus LAG-3. We also tried to be a little bit more innovative and not just put drug into the spinal fluid, but trying to learn more. And I have a wonderful collaborator, Dr. Golnaz Morad, who's unfortunately going to Moffitt now, who really is the queen of microbiome, especially when it comes to brain metastases. She just had a Nature publication last year, and I'm going to show you some data. So we're really trying to understand what's the bacterial signature actually within cancer cells in the CSF, because we can find bacterial parts or a genetic material in actually brain metastases, and kind of trying to match them to both the oral gut microbiome as well as the fecal gut microbiome. So again, trying to be a little bit more innovative in understanding what other factors might be influencing your outcomes. So we haven't published this. I had our statistician run really quickly analysis. So you can see the overall survival with Nivorella. I haven't shown you the patient population, the 20, so we finished enrollment in just 10 months. Maybe another thing for the younger folks to know in the audience, if you have the right trial or if you have an area of unmet need, your patients will come. Patients will come and seek out treatments if they have nothing else or if they're being told, you know, we don't have anything for you. So be bold and think about the unmet need. So again, we had this trial, we enrolled it, 20 patients in 10 months, and overall survival is not better than with just nivolumab, but I would say that we actually gotten braver over the time and treated sicker patients, just simply because they have been doing well and have had very low side effects. And again, we are now got recently a American Brain Tumor Association funding to actually really analyze the microbiome in greater detail and pairing it with single-cell RNA sequencing to learn if there's anything we can do or learn, again, from your gut microbiome. And again, as you know, there's a lot of data in melanoma where gut modulation or microbiome modulation, either with FMT, fecal material transplant, or a high-fiber diet might actually impact your outcomes. How this might work in CNS disease, we really don't know yet. And you also have to remember that a lot of patients with brain mets or leptomeningeal disease are on steroids, which can also significantly alter your gut, right? But again, those are all research questions where we need to work together to move forward. And as I just mentioned, Dr. Moraj just recently published this in Nature Medicine. Sorry, I misspoke. It was Nature Medicine, where again, she highlighted that when we had resection samples from brain metastases, not leptomeningeal disease, that's another part that's very hard. Brain mets are being fairly routinely taken out. Again, I had the pleasure and honor to talk earlier to Dr. Buchwald, sorry, I'm going to pronounce it German, Dr. Buchwald, you know, doing neoadjuvant approaches where you get actually part of your brain metastases. With your leptomeninges, you typically never get them. They're not being taken out because it's a diffuse process. So tissue has been historically very hard to get by. So we use the tumor cells that we find within the CSF as some of our, like, you know, surrogate markers of what we think goes on in the LMD area. However, we know that's actually not true because there's also no articles that show that the CSF cells, the cancer cells that you actually suck out through your lumbar puncture or through your Meyer-Tap are probably the ones that are not as active and alive anymore. They're kind of just floating around and on their way out, but they're actually very different than the ones that are still on the meninges growing and actually spreading. So we don't have the same data that we can really use from repeated biopsies or from having large tumor samples. But again, I just wanted to highlight that there's, again, more and more stuff that we find out how the gut microbiome, again, in the oral area actually has similar signatures to, again, bacterial elements that we can find within the tumor. So we've talked about intrathecal checkpoint inhibition, and this was safe and it's easy, it's off the shelf. But one of the things we realize over and over that there are just very few immune cells within your spinal fluid. So maybe an analogy is we always talk about a cold tumor right in the periphery. Let's say you have a metastasis and it has the cold signature. It doesn't have a lot of immune infiltration in it. How can we turn a tumor, a cold tumor, into a hot tumor, right? And we use intratumoral approaches. We use radiation maybe as priming. But we really don't know, again, how can we do this within the CSF? And there are some discussions or thoughts of maybe using low-dose radiation to kind of open up the blood-brain barrier. But I think, again, intracellular approaches are really, personally, I think, part of the future repertoire that we help combating this disease. So the hypothesis is, again, intrathecal IL-2 was beneficial, anti-PD-1 intrathecally was beneficial. We know that systemic TIL, tumor-infiltrating lymphocytes, can work in patients even who they're refractory. And as I mentioned already, the IT space is very cell poor. So the thought is, again, combining IL-2 with cells, you just put the cells in where they should be, right into the spinal fluid. Again, would only work in the LMD, right? Would not work in the rest of the body. But then again, the question is it safe if you put large amount of cells into the spinal fluid? And we did 2 patients. I know it's a lot to read. One of them was published. But long story short is you can do it. Do patients have symptoms? Yes, because they will have, again, a bunch of cells. You give it with IL-2. But the first patient especially lived really for a month after he received intrathecal TIL, but then unfortunately developed extracranial progression of disease and died subsequently from his therapy, from lack of additional therapy. The second patient was a younger gentleman who unfortunately just had rapid progression on BRAF MEK everywhere. And even though he tolerated the procedure somewhat okay, he just succumbed to disease growing everywhere. But again, I think we need even sometimes case reports to say there is initial data, and we can learn from this. And I didn't put some of the graphs up there where we kind of tracked the cells and we looked at cytokine profiles and again, flow studies. But again, we can learn from every patient. Now, one thing that I'm particularly excited about is not just TIL, because TIL come with a problem, and I think I have it on the next slide, maybe not, but you need a tumor to harvest, right? Tumor-infiltrating lymphocytes have to come from a tumor, preferred periphery, right? Because it's hard to go into the brain and take out a tumor. It's a pretty big surgery. And so it also takes time to grow. Another approach that might be easier to use is endogenous T cells that you can just get with leukapheresis. So you put like a plasmapheresis catheter in a patient. You simply just really, I'm going to dialyze your immune cells out. You allow for specific antigen recognition. And that's a much faster and easier way to derive immune cells without need for an actual tumor. Now, it still will take time to expand these cells, typically a few weeks, but you're hopefully then growing a more targeted killer cell population for these patients, and then you infuse them back intrathecally. And this is really work and things that Cassian Yi has done, who's just, again, a joy and amazing to work with. We have not injected the first patient with intrathecal ETC. We're working on it. We got 2 secret grants for this, but I think this is really something that could be part of the future regimen. And then the question is the NK cells, right? We also briefly talked about NK cells in melanoma in general. But then the question is, how often do we need to give these NK cells? Again, not so bad if you have an Ommaya. You just use the same route of administration. And again, what is the role of CAR-Ts in CNS disease and in solid tumors in general? But I think this is where the field is ultimately going. A few words on the CSF tumor microenvironment. And you might say, gosh, you know, she's been doing this for like 12 years. That's not so much data. I agree. I actually wouldn't disagree with you that you say, well, this is all what you got. But again, I think what I was trying to tell you with the timeline and the journey is it takes time and it takes a village. And really just over the last 3 or 5 years, the field, and I'm saying the field, not just physicians, but also the industry, has developed an interest for leptomeningeal disease. And again, I'm hoping that we see a more exponential interest in this particular space. But again, it takes time, right? I think research takes time and it doesn't happen overnight. So the reason I put this up, and again, some of you are familiar with MRI, some of you aren't, but the unanswered question is that really is the core of all what I do is why do some people live and why do some people not live, right? Why do some people die literally within 4 weeks of LMD diagnosis? And this is the same patient. She was diagnosed with LMD. Again, I'm going to call it the LMD for the blind. What's wrong? It's all this white stuff here. That's what we call leptomeningeal disease. On BRAF MEK inhibition, horrible symptoms. And then she did fine for 2 years on intrathecal nivolumab, which was shocking because she had ipi-nivo before. And then she developed this gnarly brain metastases. But again, to date, I cannot explain why she did so much better than I actually ever expected and could have hoped for. And this is what we're trying to do now with more translational studies. But what we know, to kind of summarize what we have learned, is we know that the CSF is in generally cell poor. But again, we know now when we tag some of the T cells that they can actually migrate in and out of the CSF. But again, how can we maybe increase the flux is one of the questions maybe with radiation oncology. We know that cytokines can be beneficial, but what do we need? How much do we need to not, again, cause patients to be so highly symptomatic? We also have, again, beautiful data now from Adrian Boar at Sloan Memorial, really highlighting the role of iron in the leptomeningeal metastasis survival. And they really just outcompete, for example, macrophages for iron. And so what she's been doing, which makes perfect sense, she's just injecting intrathecal iron chelators. So she's depriving the tumor cells right where they live within the CSF from their nutrients. I tell patients when they hear about this, I said, that doesn't mean you should have a low iron diet. That's not how it works, because people sometimes come up with very crazy ideas of how to maybe modulate. But again, I think we're learning small things about this. But again, the unanswered question is the immune cell population and cytokines in this space something that the patient shows up with? And I'll show you data, I believe, on the next slide from, actually in 2 slides, from Moffitt, where they realized that some of their LMD long-term survivors had a CSF microenvironment that was very similar to actually of normal human beings that didn't have LMD. So they kind of showed up with a good microbiome. It wasn't the intrathecal approaches that changed. It was we just had good stuff to work with, to make it very simple. But then that leads to the next question. How can we change this? Is it, again, by pouring in the immune cells that we need right into the space, or can we, again, enhance migration into this? Again, what's the role of cytokines? And there must be many other resistance and metabolic mechanisms for survival. And so I already mentioned the lipocalin one, which is really the iron promotion, how iron promotes the survival of metastatic cells. Again, published already now 6 years ago in Science. And then again, how actually the meningeal stroma is also supporting and nurturing your cancer cells. And again, how can we utilize this to maybe cut off this nurturing kind of memory approach? Again, this is the data from Dr. Chi and Adrienne Boire that, again, showed really that the cancer cells appear to survive by outcompeting the macrophages. She did really beautiful preclinical studies and really with a lot of murine experimentation. And this is now in clinical practice, but we're waiting to actually hear the final results of the trial, mainly focusing on breast cancer. I think only enrolled 1 melanoma. And like I mentioned, this is from Ina Smalley at Moffitt, who also have a very strong LMD program here in the US. And again, this was their long-term survivor patient. And again, like I already mentioned and gave you a sneak peek, that the long-term survivor was very distinct from patients who died within 2 or 3 months. What they also were able to do, which is, incredibly important, I don't know if this is possible at Emory, one of their patients, who was a wonderful, generous woman, said, when I die from my leptomeningeal disease, I want you to try to harvest my meninges for research. And they were able to do this. And what they were able to do is to really develop the first leptomeningeal melanoma cell line, which is so important, again, for preclinical work to really figure out what's going on in these LMD cancer cells. And so this was just a generous contribution for her to science. We at MD Anderson are not set up to do so-called warm autopsies, but I think it is a missed opportunity because, again, we otherwise really can't get to tissue or leptomeningeal material. So again, what have we done? And this is unpublished. We're about to submit this. So we've done a lot of translational work in our longitudinal IT-NIVO data. And again, at one point, we also want to compare this to our NIVO-RELA. And so we've done ELISA's single-cell RNA sequencing, Luminex, and CyTOF. We also have measured NIVO levels. And while I didn't put the slide up here, we realized that nivolumab leaves your CSF very quickly, and we can find it back in the periphery. So, but the question is, does it matter? Because one thing that we haven't done yet, which all of you say you should do, and I agree, is receptor occupancy, right? That's really where the meat is. You should not only find out about the levels of the drug you put in, but what is this actually doing biologically to your immune cells. And actually, Joan Hannon in the Netherlands, we actually just were on a call last Friday, and they have done this in 2 patients, and they see beautiful receptor occupancy. Again, this is unpublished data. I just want to throw this out there. But again, I think things that we all learn by really jumping on calls with each other and sharing what each of the individual groups is finding out and seeing, again, to really understand, does it matter how often we put those intrathecal PD-1 agents in, or does it actually matter? Does the dose matter? Yes or no? Maybe we achieve the same thing with 5 milligrams versus 50 milligrams, but what other areas are, again, that are completely unanswered? So I like Star Trek. I grew up with Star Trek. So what other options and targets do we have? This is for the maybe only one radiation oncologist in the audience. Again, Dr. Buchwald, this was for you. I didn't know you're going to join, but so again, if you think about radiation options, your standard of care radiation option, whole brain doesn't work, and I very rarely recommend it, only for true palliation and to decrease symptom burden, but it does not extend overall survival. We looked at 500 patients with melanoma LMD, it didn't do one thing. Actually, I think the patient who had whole brain did worse, but again, is it the whole brain? No, it's probably just the significant disease burden they have. Stereotactic radiosurgery for LMD used to be, I think, and again, please correct me, but it used to be a no-no. But I think it's become much more commonly used if you have focal nodular LMD. At least our group is really now much more willing to repetitively target certain areas. Again, I think SBRT to the spine is very different. But again, the nodular LMD in general has also a better outcome. But then two other things that I think have really been of interest is proton craniospinal radiation with Jonathan Yang at Sloan Memorial and intrathecal radioisotopes. So craniospinal proton radiation, as you all know, has been used in pediatric population quite a lot, again, for maybe there are more students in the audience. The way that I think it's highlighted very nice, you can see that the targeted proton therapy really kind of stops at the tumor. You don't have the other scatter radiation or exit dose, so that can be actually better for your organs that are in front of your spine. So when you radiate the spinal cord, it kind of stops right there without actually having all the exit dose that can affect your organs. They did a clinical trial. Again, melanoma was only 6 patients total. Again, it's a smaller number of patients in general. And the overall survival was 6.6 months. Again, you're absolutely right in saying, well, that's not great either, right? You're still not making any progress. But if you think about it, that maybe we can sequence these therapies or ultimately maybe combining these, maybe we can push the field forward to actually be at one point at an overall survival of a year. Of course, I hope that the overall survival at one point will be not reached, but I think we are still a little bit far away from it. And so again, the real world data is somewhat similar, but again, varies greatly. So multiple centers have done reports on it. This median overall survival was only 3 months, 37 patients with LMD. This was only 9 patients. Median overall survival was 4 months. And this is actually MD Anderson data. And I have to say, I have to go back, and I'm not truly believing it. And even though it's from our own institution, 13.7 months seems amazing. And I'm not sure if they really just picked fantastic patients. Again, the majority was breast cancer. And again, interestingly, even leptomeningeal disease from different cancer types has different historic overall survival. Breast cancer patients do the best, followed by lung, and then melanoma, unfortunately, is the worst. But again, I think not to think of it as the cure or as long-term survival improvement, but as an additional tool. And then finally, intrathecal radioisotopes. It's a company, Plus Therapeutics, based out of Houston, who uses it. And they use rhenium. So again, an intrathecal approach. You go straight into your spinal fluid. You do repetitive injections. And it has a very short half-life. It doesn't have a lot of, again, deep penetration. So again, we're only targeting the LM. We're not targeting anything else. And they are expanding this further to larger cohorts. And again, we seem to see a glimpse of improvement in overall survival, again, against historic control. But the question is, again, is there a role for adding intrathecal immunotherapy at the same time? Because I think historically, we always felt that there's synergy, even with SRS and brain metastases and immunotherapy, to prolong survival and decrease or improve distant brain-free survival. So I think my plea is, again, it takes time, but only together can we really push forward and make a difference. We need multi-institutional trials. I think this is very true for many bad disease types. We need to also still have even simple things like databases. We have had now the 3rd year in a row an ASCO SNO LMD think tank, which has published a white paper every year. And I think, again, getting all the people who are interested in one room and talk about the challenges is extremely useful. And I think networking can't be underestimated. And this is 5 years. Like I said, he's now 8 years, but this is a gentleman who was, and I have permission to share his photo. I should say this before actually putting it up there, but he was in a wheelchair, wasn't really able to walk, had radiation, whole brain radiation before I met him, and had prior checkpoint inhibition with Nivo and Ipi and temozolomide. And he's now, again, in his 8th year and still alive and doing well. And again, this is why we do it, so that we can celebrate these milestones. And again, as I alluded to, this is a village. I'm really just one of hundreds of people who have been crucial to push this forward. And I think with this, I have some other slides, but with this, thank you so much for your attention.
It's a great talk. Excellent work. Does anybody have any questions? Edja?
One of the neurosurgeons here, so I know the folks back at MD Anderson and my fellowship there, so Sharice and those are good friends. The cells you're getting from these patients you're treating with, whether it's checkpoint inhibition and other, as you were showing, obviously there are those long responders who do very, very well, and unfortunately many, many more that don't respond. Beyond just receptor occupancy, are there other markers within either the immune cells or even the circulating cells that you're pulling from those patients that are suggesting which ones will or will not?
Maybe we'll answer the question here. We'll repeat the question and answer it here.
So I think you're really just curious about what distincts this long-term survivors from the short-term survivors,
Or
right?
just the actual functional changes we're seeing in the immune cells or the tumor cells as far as response or non-response.
So in the cancer cells, we really haven't seen much. So there's a couple of thoughts. So in IL-2, I'm going back to the old times. In IL-2, what we would often see is an increase in tumor cells after the first kind of what we call induction period. And the thought was that a lot of the cancer cells just started dying off and then just showed up in the CSF for the first time, even if the patients were CSF naive in the beginning. In the CSF now, and we've done single cell analysis, it seems really that the long-term survivors have a very different CSF immune cell profile, much less exhaustion markers, and we see the most dramatic changes of what we work with those good responders within the first 2 doses. So the changes are seen early on and they maintain. The poor survivor, the patients with poor survival, we didn't even call them responders, we call them long-term survivors and poor survivors. They just come with exhaustion. They have just, it's just a wasteland of just immune cells. And so we really don't do very much for these patients with intrathecal checkpoint at all. There's really no change. What's there gets actually worse over time. So this is where the thought is that by themselves, again, some patients will benefit. Again, we have long-term survivors, 3 years, 5 years, 7, 8 years now, but it's probably not enough how to alter this tumor microenvironment. And this is where the thought has come in again to use intrathecal cellular approaches, unless again, we find something else that we can use to switch it back on. But again, I think it's been very clear between the Moffitt group and actually talking to Adrian Boer at Sloan too, that it seems that there's like a predefined a definition when they first show up and how they will do to all the therapies, at least to date. I don't know if that answers your question
Sure,
completely.
Other questions? Crystal, Greg, and then I think there was a question back there.
Great talk. I'm really excited about how very close you are to the TIL therapy.
Mm-hmm.
And I was curious if you could maybe elaborate more, maybe you're going through your slides, like what kind of T-cell product it's going to be and like the patients you're going to treat exactly, like and when?
Yeah, so I think, there's a couple of, so the question was TIL, intrathecal TIL, different than intrathecal ETC, right? So the problem is that right now we don't have a homegrown TIL program at MD Anderson anymore. So we don't have truly our own TIL lab anymore, so we can't really, I don't want to say experiment, but we can't grow our own product right now. This is where collaborations might be interesting moving forward. I mean, I would love to put Obsidian T cells, for example, into the CSF, right? Because part of what I love about their cells is you have, like we talked last night, an on and off switch, which is fantastic, right? For CSF, when you think again about toxicity, to have an oral drug that can turn off and on your immune cells outside of taking out some CSF fluid for pressure, giving steroids, I think is a brilliant mechanism to also provide additional safety. But any TIL product will require extra cranial tumor, and it's a long lag time, right? So I share my experience with Iovance's TIL, which is the only FDA-approved product, lifileucel. It takes about 10 weeks from the time I say you need TIL or you should get TIL to the time that the patient actually gets TIL. So we haven't made a TIL product from the CSF yet. So, and again, the reason is because we have actually not even managed to grow enough immune cells, and we haven't grown even cancer cells out of our own CSF. So the TIL would be still harvested from somewhere else, typically extracranially, but the answer would be in patients with concurrent brain metastases, wouldn't it maybe make more sense to use intracranial derived TILs, but that's way more invasive. And again, yes, and maybe that, but I think, again, the problem is a 10-week time frame for TIL in a patient who has 3 months to live, average. So I think, again, using the ETCs, the endogenous T cells, you're already saving yourself 4 or 5 weeks. So you're looking at maybe 4 weeks, which I think is much more conducive. However, you have HLA restriction. So you're limiting, again, your patient population to HLA 80201 primarily, right, and 24. So that, I would say, is a huge downside, that you're naturally already depriving 70, 60% of the population that doesn't have the right HLA type. And again, they still might deteriorate right there. But again, the other thing with intrathecal TIL, you probably need IL-2. With the ETCs, we decided to not use interleukin-2 because of the toxicity, because we have to establish first safety. And in K cells, it's something that, again, we're doing now PRAME specific NK cells with Katie Rizvani. And again, we're working on preclinical models to see, can we use them intrathecally as well? But then the question is, again, how often do we dose? When do we stop? What's the right dose? And that's really something that we've also had long discussions with the FDA. Your cellular product has to be in less than 20 ml, because you really should not take more than 20 ml out of CSF, even through pneumia, even though you replace it. But then you can also argue, even if you take out 20 ml, you instill something else in it that can cause, again, a cytokine storm, severe neurological potential side effects just from a different product coming back in. So we've been looking at ways, and we also have to still do experiments, and do the cells survive being squeezed to the needle? They will survive being squeezed through the needle, but we still have to show that they actually come out at the other end unharmed and get actually into the CSF. But again, these are things that I have to say as a clinician, I sometimes forget, but then the FDA reminds me that those are things that they would like to know.
I think we may be at time. Thank you so much.
Thank you for having me.
Yes, thank you, Dr. Glitza. If you have any questions, feel free to speak to Dr. Glitza. Before you go, just want to announce March 18th, we have another luminary in the field, Dr. Fumi Lapade from University of Chicago. And for details, just check the Winship website. Thanks.